Oh, this is Dr. Cameron. This is the last session, the last guest that I'm going to bring on, and then we're going to come to a close. But this live streaming experience, it's nice to share time. So I'm here with Dr. Ken Ligner, and interestingly, Dr. Ken Ligner and I started practice. He started, preceded me by a couple years, but we're from the same community, same hospital, share patients, and so thank you for coming, Dr. Ligner.
Thank you for inviting me.
And so Ken, being one of the pioneers, one of the things that, you know, of all the things you've done, is that that you've been a champion of case studies, case reports. The cases are really worked up nicely, but you've been able to have that gift of translating it.
I was very fortunate early on to be able to collaborate with some wonderful co-collaborators. Paul Duray, Paul Lavoie, some people at CDC, people at Rocky Mountain Lab. So it was a time that was kind of unique, and so we were all confronted with these very puzzling cases, very difficult cases, and it was fortunate that at that particular point in time we were able to collaborate. For example, the Logan case.
So during that time, that was a great period where there was collaboration by people. But the nice part about the collaboration, the working together, was that you had this ability to pick up the phone and talk to anybody and work on solving problems.
That's right. It was actually a very convivial time in the history of Lyme disease.
And I think that you had mentioned that one patient that was dear to you, that you worked on, and because she was so sick. Did you want to share anything about that time of working with someone who was so sick with Lyme disease?
Sure, that was the case of Vicki Logan, and she had come to me sick for a number of years already and had seen many expert physicians, many top neurologists in the country, and had basically a chronic meningitis of unknown etiology, and had developed a gait disturbance and a lot of other serious neurologic problems. And I had studied her for about a year and was not able to make a diagnosis. But I felt that I was not able to exclude Lyme disease because she had grown up in what had become a heavily Lyme endemic area. She didn't even give any history of known tick attachment or any rash. Her tests for Lyme were negative, but because I couldn't identify any other treatable condition that would explain her symptomatology, despite a lot of effort in doing so, I decided to purely empirically treat her with intravenous antibiotics. I did a spinal tap before I treated her, and I did a spinal tap after I treated her. I treated her for a couple of weeks with intravenous, I think it was cefotaxime or clafuran, and it didn't seem to really help her, and it didn't change her spinal fluid findings. And so I think I treated her for a couple of months with orals. Didn't make a whole lot of difference, and I kind of just backed off. And then about a year later, she contacted me and pleaded with me to do another spinal tap. And around that time, I had begun working, I'd been introduced to folks at CDC, and at that point they were interested in receiving specimens from patients that I was working with who might or might not have Lyme, and they provided me with Barbara Stoner Kelly culture media, and this was about a year after I had treated her initially, and did a spinal tap again, and at that point put a couple of cc's of her spinal fluid in Barbara Stoner Kelly media, and a couple of weeks later I got a very excited phone call from David Dennis at CDC to let me know that spirochetes were growing out of her spinal fluid, and these later were shown to be Borrelia burgdorferi.
Well, I think that so much of what you learned with being there right with someone as sick she was. So much of what you described over the years, we know affects Lyme now. So, many of those observations on one person. I think a lot of doctors learn a lot if they slow down and take on a couple patients and get to know Lyme and tick-borne, and they can build an understanding of Lyme. And so that's why you still see plenty of complicated Lyme patients now.
I do. Well, you were talking before about evidence-based medicine, and I think her case indicates how important careful study of a single patient over time, that is to say a case study, how very important that can be, how fundamental that can be.
I think that spinal tap result showing that even after antibiotics that Lyme disease can still be a problem, reminds us of the whole problem of persistent infection, because there's been so much research on where Lyme could remain, like in the brain, across the blood-brain barrier, in various tissues, intracellular, and just a whole number of mechanisms that it can be variable in its expression. So there's more and more mechanisms that you see specialists come up with to try to explain how can a persistent infection be there. Even the whole biofilm theory that Eva Sappi's been working with is another good example of what we know about mechanisms.
Correct.
And so you're finding with time, with the physicians that are out there, you still find some physicians who probably aren't too excited about working with Lyme disease.
Yes, well, it's a difficult field.
Yeah, I think it's difficult, and we need a dialogue. And so you and I have been talking about over the years of when are we going to get a proper dialogue, and when do we get conferences together where you can hear both viewpoints, And I think that hasn't come yet, but you and I, as our old warriors, we're waiting for that day where we can work together at the same level as when you were in the 80s working and collaborating.
Yes, it would be nice, because it was actually very pleasurable to have that conviviality of open collaboration.
Now, you're going to be a board member. You were elected board member of ILADS. And
correct.
So besides your clinical hat, it sounds like you're going to be busy with being an organizer, trying to so I'm looking forward to you being on the board to work on leadership in Lyme disease.
Thank you.